Hey, good day and good evening, everyone. It's Tuesday, so it's us again, live on air. I'd like to ask you if you can hear me loud and clear, and if you will say yes, it will mean that all is working just fine and that we can start.
Okay.
It's great to see you all here, and I'm glad that you decided to spend this evening with us. And thank you for the feedback. I'm Sophie, and I'm your host today. And welcome to IVF webinars by Egg Donation Friends. We are here week by week with great guests, fertility specialists from all over the world. We did 47 IVF webinars this year, and in total we have over 70 IVF webinars, and it's all recorded and available for you and for free at your fingertips on our website at eggdonationfriends.com/IVF-webinars. IVF webinars are brought to you with help of our partners, and our partners are National Fertility Society, fertility clinics abroad, and Donor Conception Network. And today, this evening, we are here with Dr. Marina Soto, who is gynecologist and obstetrician at Phi Fertility. So good evening, Dr. Marina, and good evening, Alicante.
Good evening.
Good evening. Hi, it's nice to have you here. And today we will talk about IVF and PCOS, and we will answer the question, is it a real solution for infertility caused by polycystic ovary syndrome? The presentation will take around 20 minutes, and after the presentation, we will, of course, start the Q&A session, and we will handle all your questions after the presentation. Okay, from me, this is it for now. So, Dr. Marina, if we can start, let's do IVF webinars tonight.
Okay. Good evening, everybody. Today we are going to talk about polycystic ovary syndrome and how it affects infertility. How said Sophie. So, what is polycystic ovarian syndrome? So, to understand what it is, we have to know normal menstrual cycle, the hypophysis or pituitary gland, the ovaries, and the uterus follow a sequence of events every month. The objective of this sequence is prepare body for pregnancy. So the hypophysis produces a follicular stimulating hormone, FSH, and luteinizing hormone, LH. The ovaries produce estrogen and progesterone. So the menstrual cycle, we have to know that it starts the first day of menstruation. So during the first half of the menstrual cycle, FSH increase. This increase stimulates the ovaries to develop cord of follicles, and one of these follicles stands out above the rest. This follicle is called dominant follicle. So the follicle produces rising levels of estrogen. This increase of estrogen causes a thickening of the lining of the uterus, the endometrium, and this increase of estrogen causes a release of LH in the pituitary gland. So in this moment is because of the LH peak when the ovulation occurs. And what is the ovulation? The ovulation is the release of the egg from the ovarian follicle. After ovulation, start the next phase of cycle. The follicle left by the egg inside the ovary begins to produce progesterone. And when fertilization doesn't take place, the follicle contracts inside the ovary and levels of estrogen and progesterone begin to shrink. This causes the endometrium to be removed, resulting in menstruation and the start of the next menstrual cycle again. If the egg is fertilized by a sperm, it develops into an embryo. So, what is polycystic ovarian syndrome or PCOS? PCOS is the most common endocrinopathy in women of reproductive age. Its prevalence varies between different sources, but we can say that it's around 10%. Its causes are unknown, but genetic and environmental factors appear to be involved. So, in this syndrome, there is an hormonal imbalance. There is a higher production of LH compared with FSH, and these causes are an increase in androgens or male hormones and decreased estrogen. The hormonal imbalance causes an ovulatory dysfunction. In this type of ovaries, there is an excessive follicular recruitment. A large cohort of follicles is recruited. However, the growth of the follicles ceases. So, of these are capable of growing enough to trigger the ovulation. And what happens to women with PCOS? So the changes in hormone levels cause the symptoms of this syndrome. The symptoms are these that you can see in the screen: hyperandrogenism that manifest as acne, increased body hair and scalp hair loss, absence or irregular menstrual periods, difficulty getting pregnant. This is because of the ovulatory dysfunction. And overweight is another symptom. The symptoms can be very variable, and in many cases, the first symptom is infertility. The woman has led a normal life until she has difficulty getting pregnant. So, how can I know if I have PCOS? So, to diagnose the syndrome, your gynecologist will ask you questions to make the medical history. The doctor will ask you about your menstrual period, the frequency, will make you a physical exploration to detect hirsutism, and will make you an ultrasound scan. The ultrasound description of a polycystic ovary consists of more than 12 follicles, and the diameter of this follicle size must be between 2 and 9 millimeters. Here we can see a normal ovary and a polycystic ovary. So we can see the different morphology. The polycystic ovary has these follicles small, and they are more than 12, like we said before. And your gynecologist may request a hormonal determination. In hormonal determination, we can see an increase of LH and the androgens. But due to its phenotypic heterogeneity, the diagnosis of PCOS is very complex. Doctors use this criteria for diagnosis. They have to be at least two of these three criteria, and the medical criteria are these: hyperandrogenism, ovulatory dysfunction, absence or irregular menstrual periods, and polycystic ovaries on ultrasound. So according to the combination of these criteria, we can observe four phenotypes. For the four phenotypes that are recognized are these. The most common is the A here, and this arises from the combination of hyperandrogenism, the anovulation, and polycystic ovaries morphology by ultrasound. So the 60% of women with PCOS have this phenotype. This is the most common. The next phenotypes, B, consist in the combination of hyperandrogenism and anovulation, and absence of ultrasound criteria. The next, C, is called the ovulatory phenotype, and that's because arises from the combination of hyperandrogenism and the polycystic ovaries morphology by ultrasound, but the women who have this phenotype don't have the problem of ovulation. And the last one, D, arises from the combination of anovulation and ultrasound criteria. This is the minority group without hyperandrogenism. Well, so what treatment options do we have to PCOS? So if exists overweight, one of the most effective approaches is weight loss. With diet and exercise, we can get it. It's known that if we lost 10% of our weight, we can restart the ovulatory cycles. Sorry. If the woman is not looking for pregnancy, we will recommend contraceptives, oral or administration, or another way administration like vaginal ring, because they are effective for treating hirsutism and acne, and for regulating menstrual periods too. Another option is the anti-androgens. But what happens if we are looking for pregnancy? Which is the problem in these women? So, like we are been explaining, the main problem is an ovulation. Well, if the woman is looking for pregnancy after a year she isn't pregnant, she should consult the specialist. And assuming that the only pathological factor is the lack of ovulation, then we are going to comment the available assisted reproduction techniques. And the first step, the first line of treatment, it's clomiphene citrate. Clomiphene citrate is an oral medication, an oral treatment. It's an ovulation inductor, and it stimulates the ovaries to release one or two monofollicular or bifollicular cycle, or to release one or two eggs. This treatment is the first step because it's easy and it's economic. You can see the scheme of treatment in the next picture. You must start taking the tablet the 3rd to 5th day of the cycle during 5 days. And then it's necessary an ultrasound control. With this ultrasound scan, with this ultrasound control, we must check a follicle growing. When the follicle achieves an adequate size, is administered the CHG. And we know that the ovulation occurs 36 hours after. So then we recommend coitus. The main risk of this treatment is the multifollicle development, and therefore the risk of multiple pregnancy. So if we have more than one follicles, the couple has to know the risk of multiple pregnancy. Ovulation rate in these cases is so high, about 80%, but a cumulative pregnancy rate in 6 cycles is around 40%. Well, if a woman doesn't get pregnant with the citrate, the clomiphene citrate, artificial insemination is the next step, the second step. It consists of an ovarian stimulation with low doses of gonadotropins to achieve development of a follicle. The gonadotropin is FSH, or follicle stimulating hormone, in subcutaneous injections. You can see the scheme of treatment in the next picture. You must start the 3rd day of the cycle with the ovarian stimulation. Then it's necessary an ultrasound control. With this control, we must check a follicle growing. And when the follicle achieves an adequate size, is administered CHG. Like we said before, the ovulation occurs 36 hours after, and then is when the semen is introduced in uterine cavity. The semen sample is collected the day of insemination. We have to say that the insemination is a procedure that we do in the consultation. It isn't painful, and it doesn't need anesthesia. 14 days after, we make a pregnancy blood test. We have to be careful with multifollicular development, and we have to, the gestation rate is around 15% each cycle, in one cycle. Cumulative rate can achieve around 30-40%. So if a woman doesn't get pregnant with artificial insemination, in vitro fecundation is the next step, the third step. So it consists of an ovarian stimulation with high doses of gonadotropins to achieve the development of multiple follicles. You can see the scheme of treatment in the next picture, and you must start the third day of the cycle with the ovary stimulation. Then it's necessary ultrasound control. With ultrasound, we must check follicles growing. And when the follicles achieve an adequate size, the ovarian punction takes place. The ovarian punction consists of suck the liquid from the follicles with a needle through the vagina to obtain eggs. The punction is performed in operating room with general anesthesia. Then the fertilization of the egg is carried out in the laboratory. The zygote is subsequently left in a growing medium, and between 3 to 6 days after, the embryo transfer is made. Sometimes, because of a very high number of follicles and risk of ovary hyperstimulation, we prefer to postpone the transfer. So then, and in these cases, after fertilization, the biologist frees embryos. And in the next cycle, we can prepare the endometrium of the woman to make the embryo transfer. 14 days after, we make a pregnancy blood test, and with this technique, the gestation rate is around 75%. So to finish the presentation, these are the main messages to take home. PCOS, or polycystic ovarian syndrome, is characterized by hyperandrogenism, ovulatory dysfunction, and overweight. The first manifestation may be reproductive dysfunction, but many women can get pregnant without difficulty. Main problem to get pregnant is anovulation, and clomiphene citrate is the first step of treatment because it's easy and cheap. Artificial insemination is the second step, and if none of the above treatments have been effective, the next one is IVF or in vitro fertilization. So, is it a real solution for infertility caused by polycystic ovary syndrome? So we can say that yes, it is. And that's all. Thank you for your attention.
Yes, and thank you for your presentation, Dr. Marina. And we have some questions already asked, so straight to the questions. The first one will be, I've read that there's surgery treatment. Am I right?
Yes, there is a surgery treatment that is called ovary drilling, and it consists of make little holes in the ovaries, your ovaries, by laser or by a needle, or with a needle. But it's an invasive method, and only it's indicated if it's necessary a surgery for another reason, laparoscopy for another reason. But yes, it exists.
Perfect. Thank you for the question and, of course, for your answer as well. The next question will be this one. If I have PCOS, will my daughter have it too?
Like I said before, causes of PCOS are unknown, but genetic factors like environmental factors are related. So if you have PCOS, it doesn't mean that your daughter is going to have it, but maybe she has a higher risk than another woman.
And perfect. Thank you very much for your answer to this question. The next then will be this one. I have read that there was a study that women with PCOS seem to have a higher rate of live birth after undergoing IVF with frozen embryos compared with fresh embryos. Is it something that has been confirmed and you agree with it?
Okay, one moment. I'm reading. Yes. I think the thing is like I said before, sometimes because of the risk of hyperstimulation, that in these patients are higher than in another patient that we make IVF cycles with for another reasons. It's better to freeze the embryos, the embryos, And then in another cycle, we prepare endometrium and we make the embryo transfer. But higher rate of live birth with frozen embryos. So depends of number of follicles at the time that when we are making the ovarian stimulation. So depends of the number of follicles in that time. If the number of follicles are okay, are right, so it doesn't matter to make embryo transfer in fresh.
Yes, and huge thank you for answering this one as well. The next question on the list is this one. My doctor prescribed me metformin. Is that good?
I didn't say nothing about metformin, but in patients with PCOS, it's more frequently that, how can I say, it's more frequently the association with insulin resistance. So metformin is often used to treat type 2 diabetes. So metformin may help with PCOS in these cases of insulin resistance. And maybe helps or improves the insulin's ability of these patients to lower the blood sugar levels and insulin levels and androgens levels too. So yes, it's good because in many cases with insulin resistance is needed. Yes.
And thank you for explaining this to us as well. And the next question we will take a closer look at will be this one. Will I have any problem in pregnancy with PCOS?
In pregnancy, so if you have PCOS and you are pregnant, you can have a normal development of your pregnancy. You have to worry about that. But it's right that in these patients there is higher rate of miscarriages and gestational diabetes and preeclampsia.
And perfect. And thank you for sharing this with us. The next one will be this one. Does it mean quality of my eggs are worse because I'm producing more eggs during cycle?
No, it doesn't mean that quality of the eggs are worse because the number of the eggs during cycles. But it's true that in some studies it said that quality eggs in patients of PCOS are worse, but it's not very clear because it depends of the phenotype of PCOS, but it's not because of the number of the eggs.
And we will now jump to the next question on the topic. Hello, thank you for your presentation. I am 43 with PCOS. I have had two failed IVF. Second IVF was very poor quality, so no transfer. I am currently on metformin 1500 milligrams daily. Will this help with egg quality? AMH level is 16. Should I still continue to try with my own egg or should I go for egg donor? Many thanks.
Well, here there are two disease or two things to consider. First is PCOS, and the second one is the age of your age. With 43 years, the quality of the eggs, because of the genetic information with that age, we recommend egg donor, but because of the age, because of the genetic information of the eggs in that age. With more than 40 years old, there are a lot of aneuploidies in the embryos of eggs with these patients because of the age.
And again, huge thank you for your answer to this question. And we have the next question, and this question is this one. Apart from Clomid, is there any other tablets you can suggest? Because I've had ovarian cyst in the past.
Yes, Clomid or clomiphene citrate are like we saw an oral treatment, and there are another tablets called letrozole or aromatase inhibitor. I think this is the aromatase inhibitor reduce the peripheral conversion of androgens to estrogens, blocking this enzyme aromatase, and consequently a decrease in estrogen levels and its negative feedback in pituitary gland. Resulting in increased gonadotropin release. So it's seen that it's useful. Letrozole is useful, but the problem that we have, I don't know if in other countries, but in Spain, that this use of letrozole, it isn't right in its medical technique sheet, so we can use it for this.
Thank you for your answer to this question. And we indeed have the next one. What test would indicate to proceed with donor eggs? I am 36 and failed last IVF. Maybe the clinic was not good? I had 20 eggs and 5 embryos day 5.
What test will indicate to proceed? Yes. Well, to proceed with donor eggs, we have to have the really we only have to check that your endometrium is okay. You don't have any problem in your uterus cavity, and have a donor and have sperm capable to do the fertilization. And then we only have to make the embryo transfer with donor eggs.
And thank you for your opinion, Dr. Marina, on this as well. And of course, straight to the next one. Is it also true that women with PCOS have 30% higher levels of AMH hormone than normal?
Really, I don't know if it's 30% or more or less, but it's true that the levels of AMH or hormone are higher than normal, that in the other women. Really, I don't know if it's 30% or 40 or 25%, but yes, it's higher.
Okay, understood. And let's take a look at the next one. What is the ideal thickness of the endometrium for an embryo transfer?
Well, the ideal thickness is around 9, but it's important the appearance of that endometrium too. So we like a trilaminar endometrium, but yes, more or less about 8, 9.
And thank you for your explanation to this question. Then next on the list is this. Is there something I can do to lower FSH? I have read that PRP can help, but this is experimental procedure still. Or is it getting some positive reviews already?
Really, I don't know if there is any experimental procedure, any study ongoing, but really you can't do anything by yourself.
Perfect. Thank you for answering this question for us. And the next one will be yes, this one. What should a woman do after a transfer for optimal implantation? She should go on bed, rest for a few days, or walk around or exercise.
Yes, we recommend that the day of the embryo transfer, you should be more relaxed and don't make any strong exercise. But the days after, you can make normally life.
Yes, and thank you, Dr. Marina. If anybody have any more questions, this is also the final call for questions. In the meantime, I will ask the question which we received on our social media, and I will publish this in a second. Yes, and here it is. Can I have PCOS and be unaware of it, meaning I have irregular cycles but no other symptoms? Is it possible that the diagnosis is not correct, or if diagnosed, it's 100% sure that I have it?
Well, like we saw before, there are 4 different phenotypes. So in one of them, you don't have hyperandrogenism. In another, you have normal cycles, regular cycles. So it depends on the phenotype. if you have at least two of the three medical criteria, you can diagnose PCOS. But yes, you can have PCOS and you can have irregular cycle, but no other symptoms are very variable. That's because it's very complex, the diagnosis.
Yes, of course, and thank you for this answer as well. As I've just checked, we handled all the questions. You actually answered all of them, and big thank you for that and for sharing the knowledge with us this evening, Dr. Marina. So thank you for your time and for being with us
Thank you. It's
from
been a
all.
pleasure for me. Thank you.
Thank you. Thank you from all of us. And of course, I would only remind you that the recording from today will be available on our website and uploaded to our YouTube channel tomorrow. So if you need a rewatch or you want to share with anybody who may need this information, because statistically 1 woman in 10 is affected by PCOS, so maybe your girlfriends may need those information, you can share it with anybody because it's free and it's available for you all the time. Please follow us on Facebook and on Instagram so you will be always up to date and you will never miss any information from us. Thank you one more time, Dr. Marina and Phi Fertility, and good night to Alicante, and see you back here. Bye.
Bye.